Okay, we're going to continue our discussion this week with Chapter 6, beginning to resolve complicated mourning, complicated grieving. We're going to go through some basics, some therapeutic basics in Chapter 6, and then we're going to get some much more in-depth the next lecture tonight on my chapter on the comprehensive model of grief and loss and regret therapy. So let's look at Worden's notes here. Grief counseling or grief therapy. So grief counseling is to facilitate the tasks of mourning and the recently bereaved in order that the bereavement process comes to successful termination. And I know we discussed that it's never truly over, but to move through that grieving period and to be able to reevaluate and to move on with successful living. Grief therapy, to identify and resolve the conflicts of separation which preclude the completion of mourning tasks in persons whose grief is absent, delayed, excessive, or prolonged. The relation of these conflicts necessitates experiencing thoughts and feelings that the patient or client has been avoiding. And remember, resistance is the result of a client not wanting to re-experience emotional pain. And so the result of that is resistance. Resistance takes a number of forms. Not wanting to talk, not wanting to re-experience, not wanting to bring about those emotions, deflection, humor, whatever it might be, changing the topic. So, as we stated in the last chapter, therapy appropriate in situations falls in 4 categories. The complicated grief reaction is manifested as prolonged grieving. And by prolonged grieving, I personally think about it as the normal grieving period is that year of firsts. To re-experience all of those holidays, occasions, a year without the physical presence of other. Prolonged grieving takes much longer than that first year. It manifests itself as delayed grief. Number 2, delayed grief may be perhaps it was an experience of trauma. Perhaps there was the use of medication. Perhaps for whatever reason the grieving process was delayed. So those emotions were never experienced or worked through. Number 3, it's manifested by an exaggerated grief response. Excessive depression, major depression, anxiety, phobias, post-traumatic stress disorder. Usually a diagnosable condition. It manifests itself through some masked somatic or behavioral symptomology. Often the client is unaware that grief or complicated grieving is the root issue, so they'll come in with a different presenting problem, and it may take a little assessing to figure out that, oh, this client is experiencing complicated grieving, and that's the underlying issue. The greater the underlying conflict, the greater the resistance. Acknowledge the difficulty clients experiencing. When resurrecting the past or unfinished business, particularly when they experienced previous reasons for resistance or perhaps a lack of support. So we've talked about all of the things that people run into. Oh, you should be over this by now. Or a lack of empathy, a lack of support. The first thing I do with an individual, whether it's in individual therapy or group therapy. I acknowledge how difficult it is to experience the emotions associated with grief and loss. And there is such a drop-off of people discontinuing therapy, not returning after that first session because they just don't want to face those painful emotions. So I tell them outright, I say, I acknowledge the pain, and I also say, you're not going to want to come back because you're not going to want to address these painful emotions, but I will be here to help you work through them. The first thing you have to do is come back to therapy, come back to the group, come back to individual therapy. So I address that right off the bat. Therapy usually takes place in an office setting, individual or group. Clients are usually seen once a week for approximately 8 to 10 sessions. Sometimes that's every week, sometimes that's every other week. I don't have a longer period of time than 2 weeks in between sessions. Though this is just a guideline, can be changed depending on the therapist and needs of the client. Many times an additional pathology emerges, may or may not affect the grieving process. They may have comorbidity, another diagnosable issue. Procedures for grief therapy. First, we have to rule out any physical disease. We set up a contract to establish an alliance, to work together, to build a trusting therapeutic relationship. We go through all of the things about confidentiality and all of those basics. We begin to revive memories of the deceased. And this is where emotional pain is first experienced or re-experienced. This can be done in many different ways. Bringing in pictures, a song, a letter, reminiscing, sharing of memories. Stories, narratives. Assess which of the 4 mourning tasks are not complete, and it could be more than one. Deal with the affect, emotions, or expression of emotion, or lack of affect stimulated by the memories. Do they have appropriate affect? Deal with the affect or lack of affect stimulated by the memories. Explore and diffuse linking objects. So it could be that an individual doesn't want to ride in a car if they were in an accident, or they don't want to go into a specific room, or whatever linking objects have meaning. We want to find out whether that's positive or debilitating. Acknowledge the finality of the loss. Deal with the fantasy of ending grieving. We can't just stop grieving. We have to work through grieving. Help the client say a final goodbye. There's a lot of creative means to do that. Be writing a letter, setting it up in a balloon. It could be anything. But how would they like to say a final goodbye to that individual? Ritual comes into play. If they were not able to attend a funeral, they were not able to view a body, if a body wasn't present, if a body was not able to be recovered, how could they bring closure and say goodbye? Special consideration. It's important to complete the grief work fully. If you stop at some point, therapeutically, usually the grieving cycle will stop at that stage. Be aware that clients may experience overwhelming emotions and warn them about this. Process these emotions and give them a support system. Be sensitive to the awkwardness that may accompany grief therapy, the clients in social situations. Even though the loss occurred previously, emotions may occur as if it had just happened. And that's usually the case. Techniques and timing. I really begin with person-centered attributes and techniques, everything Rogerian. To be present with that other individual or group of individuals, to build a trusting relationship, to accept them fully, to be genuine, and to be empathic. Use all of the basic techniques from Skills and Techniques. Role-playing and psychodrama, we'll go over them in the next lecture with regret, role reversal, and personification of the feeling. Usually those three things go together, and we'll go through the whole thing. I prefer role-playing, role reversal, and personification of the feeling instead of empty chair. I just think it's easier for a person to talk with another person and to pretend they're somebody else than to pretend there's somebody sitting in an empty chair. Use I statements. They need to own their grief, to own their feelings. Bringing unfinished business into the present. So now we're really getting into more Gestalt techniques. Timing and understanding when to use the appropriate technique is essential. Learning when to use silence. But the overarching therapy that I use is existential therapy, to find meaning in the relationship, in other. What meaning did that other individual have in my life? What meaning do I find in that other individual, in this loss, in this death? How has this experience of other changed me as a human being, and how will I carry that other individual with me? How will I redefine my life and this relationship, and how will I move on with my life as a result of that new definition, that new meaning, that human growth and development? Dreams in grief counseling and therapy. Dreams may parallel the mourning process. That is perfectly normal. They may reflect feelings or help to process feelings or anxiety. Dreams aren't good or bad. They allow the client to interpret the dream in any meaning. I don't interpret dreams. The deceased may appear in the dream or may not. Dreams could be symbolic. Dreams can show where an individual is stuck and help them to progress. Most importantly, I ask them to identify a feeling in either a repeating dream or a lucid dream that seems realistic, like it's actually happening. What was the feeling that the client was experiencing? It could be a feeling of helplessness, of fear, and then I ask them to attribute that feeling to what they're experiencing in their waking life. And that's how I make a connection between the feeling in the dream and the real life experience. What's the fear you're experiencing now in real life? What's the helplessness you're experiencing? And then we process that emotion. But often a dream is a jumping off point. All right. Definitely watch our next lecture on a comprehensive model of death, anxiety, grief and loss, and regret therapy.